Hi everyone, my name is Dr. Eric Waldon, and I'm an Associate Professor of Music Therapy at University of the Pacific. Today I'm going to talk to you about an overview of evidence-based approaches in music therapy. And this is really about defining what it means to be evidence-based, maybe discussing some of the counter-arguments to why evidence-based approaches are not appropriate for music therapy, and giving an idea of what you can do to encourage more of an evidence-based culture in our profession. So let's start off by talking about what evidence-based practice is. It's a term I'm sure many of you have heard before. And this one we pull from our friends at Florida State University. So it's an approach to healthcare decision-making in which clinicians use the best available research evidence, clinical expertise, and consideration of patient factors. So we can look at this diagram, and you can see, just like the definition, there are three parts to evidence-based approaches. We'll start with the first part there, best external evidence, and I think this is probably what gets the most attention in evidence-based discussions, but it's not the only part, and I think that's where a lot of people have some misconceptions about what evidence-based approaches are. So we'll talk more about the best external evidence, but this really refers to the body of research literature that's available to support an intervention in a profession. In this case, we're talking about music therapy. And even though it says above healthcare decision-making in the definition, we can apply this to educational settings, wellness settings as well. So the first part is the best external evidence. That's referring to the research literature. The next part that's here in this green portion of the Venn diagram are the patient values and expectations. I also like to add in the word factors. So what we know about healthcare outcomes, success in patient outcomes, has a lot to do with the extent to which the evidence that's available links up with the specific patient needs. So if we're looking at this diagram, we're looking maybe at this overlap area right here. So this little overlap area is the extent to which the research evidence is lining up with the needs of the patient. It also has to do with a sense of hope in the patient that the intervention that's being used somehow is going to address their needs, or it meets with their expectations. We often talk in psychotherapy about one of the common factors that predicts success is that there is a hope that the treatment is going to work. And that has a lot to do with whether or not a patient is successful. Because a patient that feels some hope, that feels that the expectation of gaining some sort of positive outcome determines whether or not they follow through with maybe some sort of at-home exercises, or that they follow the directions or the directives of a physician, or in this case, the music therapist. The third part of the evidence-based triad is individual clinical expertise. Again, a lot of people don't realize that this is part of the definition of an evidence-based approach, but this has to do with the experience of the clinician. How well they're able to execute an intervention. So if we're looking at this piece of the diagram, we're looking at, we have an intervention that's terrific. Now, what about the clinician's expertise? How well can they carry out that intervention in the way that it should be carried out? For music therapists, that also has to do with your musicianship and how well you're able to execute the musical components of what it is that you're doing. But we can also look at this overlap right here. So the overlap between those patient values, expectations, and factors and the individual clinical expertise. This has a lot to do with a therapeutic relationship. And we know, again, from the psychotherapy literature, that one of the best and strongest predictors of positive outcomes in therapy has to do with the strength of that therapeutic relationship, particularly from the perspective of the patient. So if the patient perceives a positive working alliance with the therapist, the more likely that a good outcome will result. And if we look right in the middle, we see that's evidence-based medicine or evidence-based practice, or really an evidence-based approach, is a combination of the best external evidence, those patient values and expectations and factors, and the individual clinical expertise. So that's the definition of evidence-based practice that we're going to be working from. So because so many people focus on that best external evidence, let's spend some time talking about what that is. So how do we judge that evidence? Well, what we really do is we look at the evidence that is available. And we look at it in terms of the quality, or what we'll say is the strength of the evidence. I think it's important to note that just because you have a study or a handful of studies doesn't mean that the evidence that's there from just having some studies published, it doesn't mean that it is strong evidence. So what do we look at? Well, we look at the research design. Is the design appropriate? Are we looking at randomized trials? Okay. Are there some sort of controls that are in place? We're looking at quality of those designs. So are efforts being taken to minimize error or minimize bias? We're looking at things like the sample. How representative of the clinical population is that sample? Did you have people drop out of the study? That could certainly cause some error in interpreting the outcomes. Look at the measurement that's being used. Are the measurements appropriate? So there are a number of things that we look for with regard to quality, and I would refer you back to some of your research classes that you've had when maybe you've critiqued some research studies that you've reviewed. And again, we're talking about precision. Again, minimizing error in terms of measurement, etc. So we're looking at the strength of the evidence. So simply having some studies doesn't necessarily mean that they're good quality studies, or they really lend a lot of support to the research evidence. We also look at things for the size of the effect. Now, one of the things we always kind of get drawn to is the p-value. Is it a significant effect? Well, beyond the whether or not something is statistically significant, we want to see whether or not it would make a real-world difference. So one of the things that we look for, especially in quantitative studies, is we're looking for effect sizes. Okay, some sort of judgment of whether or not this is going to make a real-world difference. And talking about effect sizes is really beyond the scope of this particular presentation, but we're just as concerned about the size of the effect in the real world as we are about p-values and statistical significance. And then we also look at lower levels of evidence coming from maybe non-randomized studies, looking at single subject designs, and even looking at expert opinions. In talking more about different levels of evidence, we can look at a hierarchy pyramid, okay, or an evidence-based pyramid. And so the general thinking is that as you move towards the top of the pyramid, it's of a higher rigorous quality, and as you move towards the bottom of the pyramid, it's not quite as strong. Okay. Something else you should note is that we tend to add a lot of weight to what we call systematic reviews or meta-analyses, which are collections of studies which are kind of grouped together and judged as a body of evidence rather than individual studies. So we have these systematic reviews really more towards the top, and we look at these maybe single studies, whether they're RCTs or non-experimental studies like cohort studies, are kind of in the middle. So we tend to lend more weight to groups or collections of studies than we do to individual studies. I'll often talk to my students and my colleagues about having a single study that may be really well designed. A single study does not make a body of evidence. Okay, what we want to see is we want to see a preponderance of evidence based on a number of high quality, rigorous studies before we can start to make some judgments. So how do you know when something's considered to be of sufficient research evidence? How do we know there's enough evidence supporting it? Well, there are a number of guidelines available, and it also depends on the discipline that you're in. There are some groups that judge this evidence. They're non-affiliated, kind of bias-free groups of clinicians that make these types of decisions, or research clinicians that make these decisions. One is the Oxford Center for Evidence-Based Medicine. We'll look at that in just a moment. We have the Melnick and Feinheit-Overholt levels of evidence. We'll look at that one in a moment. And then we'll talk maybe with a little more depth about the Cochrane collaboration. So these are groups, collaborations that make some judgments about a body of evidence. So they do the judging, and they're the ones that make a kind of an objective decision regarding a body of evidence. So here is the Oxford levels of evidence, and as you can see towards the top, they give greater weight to those systematic reviews, and then at the bottom they give less weight to just expert opinion, or sometimes what I will call kind of the seems to me evidence. Seems to me means it's not really based in any kind of systematic research approach. It's just based on someone's expert opinion. We tend to put that towards the bottom. Very similarly, we have the Melnick and Feinheit-Overholt levels of evidence as well. Again, level 1 at the top, we're looking at systematic reviews, meta-analyses, etc. that happen towards the top. And then as we move down, we have single randomized controlled trials, and again, moving towards the bottom of the strength of evidence is expert opinion. Now, you're saying, well, why are we putting the expert opinion at the bottom? You'll also notice that qualitative studies are also in this hierarchy as well. And it isn't so much that we're not saying those things aren't important. I will often say that we can learn a lot by looking at the totality of a body of evidence. But when we're looking at just the research evidence itself that might be lending support maybe to third-party reimbursement, etc., we're looking at giving more strength to level 1 types of evidence over other types of evidence. It's not to say that those other types of evidence aren't important. In fact, we know that clinical expertise, okay, holds an equal place in that evidence-based model. Okay, remember the three-part model that we just talked about. So expert opinion is really important. It is a part of the evidence-based practice. The research evidence itself alone only talks about how well an intervention behaves in a very controlled setting. We need to know more about the clinician's expertise, their skill at executing these things, the thought processes of the clinician as they're executing interventions, and the only way to get to that information is through qualitative inquiry or asking about their expert opinion. The same thing with the patient factors and their expectations and their values. While we can look at some of those things, expectations and values, quantitatively, the best way to get at that level of evidence or that type of evidence is to run qualitative studies. We need to find out what's going on within the patient. What are their perceptions of how they're interacting with the therapist, or the extent to which they feel hope or they feel encouraged by the intervention that's being used. The only way we can get to that is through qualitative evidence. So qualitative evidence, expert opinion does have a place in the evidence-based paradigm. But when we're just talking about best external evidence, we really focus on this quantitative evidence and looking first at systematic reviews. So let me tell you a little bit more about another collaboration we call the Cochrane Library, the Cochrane collaboration. This is an international body that judges a body of literature. It's cross-disciplinary, meaning we have this in medicine as well. Physicians will look at the Cochrane Library as well, these systematic reviews, to look at what are the best practices in certain areas of medicine. And within the Cochrane Library, they do systematic reviews of music therapy interventions. Here are just a few of the areas where you can find music therapy in the Cochrane literature. Sometimes you can look up music therapy and autism, and you'll find a Cochrane review looking at the literature base in music therapy and autism. Most universities will have access to the Cochrane Library, and you would search through the Cochrane Library in much the same way that you would looking for an article or anything in your university's catalog. And so here's a search that I did at University of the Pacific, and you can see some of the research or some of the Cochrane reviews that they have. So with cancer patients, mechanical ventilation, ASD, preoperative anxiety, people with psychotic disorders, acquired brain injury, and depression. What's important for you to realize is when you look at these Cochrane reviews, sometimes it's specifically looking at music therapy, sometimes it's looking at just music interventions, which are different from music therapy, as I'm sure you all are aware. And when you look at one of these reviews, they will give you a full review, which is dozens of pages long, but they'll also give you short and summarized, plain language summaries as well. The longer reviews are really nice because they give a breakdown for all of the studies that they've included in the systematic review or the meta-analysis that they've done. So it can break down those studies for you. And they'll also talk about the studies that they looked at but they didn't include in the review for maybe one or a few reasons. So I think this is an excellent place to look for a body of literature in music therapy or in music-based interventions, music medicine, for example. Now, there's a caveat to any of these reviews. It's that these are being conducted by people. So these are being conducted by people. They are, and people are coming with their own biases with regard to the literature. And so we can try to be as objective as we can, but they're still subject to bias in terms of which studies they've looked for, which ones they've decided to include, etc. But these are professional researchers, and they are doing the best that they can in making a decision. So always remember that these are systematic reviews that are being conducted by people, and people do. I like to say there's no such thing as a view from nowhere. These people are coming to these reviews with some bias in mind. There are many music therapists that are part of these reviews as well. Yoka Bratt, for example, is here. Cheryl Dillio, Christian Gold, Wendy McGee. So there are music therapists that are on these review panels. So we've really focused a lot so far on the external evidence and maybe pulling back the curtain a little bit on what it means to look at evidence, what is considered to be, the rigorous evidence, the high quality evidence, the strength of the evidence. Now we're going to move on and we're going to talk about some assumptions, and these are my kind of assertions about why a music therapy profession that is embracing an evidence-based paradigm is important. And so my thesis is that it's important for us to embrace an evidence-based approach. And so number one, the first assumption is an evidence-based discipline is desirable. So we're going to talk about that first. And then we're going to talk about how an evidence-based approach is compatible with the music therapy clinical practice. And then the third assumption is we're not quite there yet. We're not quite as evidence-based as we'd like to think we are. So let's look at that first assumption about an evidence-based discipline is a desirable thing. It's something that we want. Now, it's important, I believe, to talk about the kind of the counter-argument to an evidence-based approach in music therapy. And I think we can learn a lot about the discussion by looking at the counter-arguments. So what are the areas of concern about embracing an evidence-based approach in music therapy? Well, many believe that it's not appropriate to adopt a medical model in a profession that's like music therapy. And when we talk about a medical model, we're really talking about a positivistic approach. That's where we're looking for cause and effect, or we're looking for predictable outcomes in music therapy, and using a quote-unquote hard sciences approach. So that's one of the arguments made by one of our music therapy colleagues, Ken Egan. He wrote an article, and I have my references at the end. So I think it's a really important essay article for you to read. That a medical model is not really appropriate. Furthering some of these concerns is that music therapy doesn't follow kind of a consistent protocol. So you can't protocolize what it is that we do in music therapy. And therefore, the body of evidence that we have from randomized clinical trials, etc., like that, isn't really grounded in realistic practice in music therapy. So the idea here is that because the way that music therapy is practiced doesn't look like it does when we're studying it in a randomized controlled trial, you can't use kind of this medical positivistic cause and effect approach. So the research doesn't reflect realistic practice. Some argue that the approach itself doesn't honor the complexity and the diversity of our therapeutic stimulus, which is music. And that an evidence-based discipline might ignore the therapist's expertise and their skill. Continuing with some areas of concern, an evidence-based approach would restrict the clinical option for music therapists, so it's very restrictive. Some people argue, why are we even following kind of this medical model or this hard sciences approach to studying music therapy? Some people say that we're doing it for the wrong reasons, and what we're trying to do is we're trying to gain some status in the eyes of our more medical or scientific colleagues from other professions. Other people say that there's only certain types of evidence which are even being considered in an evidence-based approach. Really the bias here, or the argument here, is that only quantitative evidence is being used. And there are some others as well. I've just summarized and highlighted some of the most profound arguments. So we have adopted, at least the American Music Therapy Association has adopted evidence-based practice and integrated it into our definition of music therapy. So evidence-based music therapy practice integrates the best available research, the music therapist's expertise, and the needs, values, and preferences of the individuals served. I think it's interesting to note that our definition, the one that's been adopted by AMTA, honors that three-part model of evidence-based approach right in our definition. So we have the best available research, the music therapist's expertise, and the needs of the client. So in our definition itself, it does counter some of the concerns about adopting an evidence-based approach in music therapy. One of the other criticisms is that we don't honor other types of research evidence. And there are other approaches or other models of evidence-based discipline. Something that's called evidence-informed practice. And an evidence-informed practice is one where we're looking at other sources of evidence, not just quantitative evidence. So we're looking at qualitative studies, or we're looking at systematic reviews of qualitative studies. We tend to see this not in music therapy, not in medicine as much. We have seen it in social work in the United States, but we tend to see it more outside the United States, in Europe, for example, where they are embracing multiple forms of research evidence. I actually like this approach to evidence-based medicine or practice, because evidence-informed practice does honor various forms of research evidence. But again, it's not very clearly defined in the literature, but this is certainly a form or a format that music therapy can take on. And again, I would remind you the evidence-based model that we're working with for this presentation today is looking at that research evidence combined with patient factors, which include things like the patient expectations, values, and also how well that the intervention matches up with the needs of the patient, and also looking at the clinician's expertise and their skill with being a musician and executing the intervention, and also building a therapeutic alliance with the client. And we combine those things together, and what we're looking for is a desirable and a predictable outcome for our therapists. When I have spoken to colleagues and clinicians about embracing a research attitude in music therapy, they often have concerns about being restricted by what the research evidence is saying. And also, if someone's studying what it is that we're doing as music therapy, what happens if we discover that what we're doing is not working? That's a concern that some clinicians bring up to me. My kind of counter to that is that, well, you've been working for X number of years, and obviously you've been meeting some success, so obviously what you're doing is working. Wouldn't it be important to be able to study what it is that is working for you and being able to share that with other people? And that's really what research is about. It's identifying what is working best for our clients and then sharing that knowledge with other people. Here's a brief humorous kind of tongue-in-cheek video that kind of satirizes what evidence-based approaches are not. So take a look.
Hello, I'm Dr. Aziz. How may I help you?
I think I have had a stroke and am worried that I will have another. I do not know who to turn to.
I am not just a regular doctor. I am a senior professor in neurology and a highly respected research scientist. I am very careful to practice only evidence-based medicine.
Yes, Your mother must be very proud of you, and I am sure your wife adores you. But I was hoping to find a doctor who practiced patient-based medicine.
I need to determine if there is a research paper that addresses treatment for your unique situation with a strong probability of success. I assume you have heard of the p-value, which is used to determine whether or not I can help you, since it refers to the strength of the evidence.
Yes, I have heard of the p-value, but my gynecologist says it is a measure of the strength of my diuretic.
Please tell me about yourself.
I am 45 years old, divorced, have 2 adult children living at home, and am menopausal.
Unfortunately, only one of the several hundred recent stroke trials included a 45-year-old divorced menopausal woman with 2 children, but they were not living at home. Please come back when you have had another stroke. The situation has a much better p-value, and I will know how to treat you.
How long will I have to wait?
I think it will be very soon.
How do you know?
Just call it a hunch.
Okay, so you can find the same video on YouTube, and it's meant to be very tongue-in-cheek. It's meant to kind of satirize what a lot of people think about evidence-based medicine. It's supposed to be kind of herky-jerky and kind of like primitive looking animation. But there are a few things that are obviously very wrong about that. Number one, the quote-unquote doctor that's there is not a clinician. Okay, so they don't have any clinical expertise in being able to carry out whatever the research literature happens to say. And then this clinician, not a clinician, is certainly not building a relationship with this patient. And he's also talking exclusively about the p-value, so looking at statistically significant outcomes and findings. So that's obviously not the most important piece. As I mentioned earlier, we look at effect sizes. And he's also defining the research literature far too narrowly. And that's not how evidence-based practice works. So if you come across someone that talks about evidence-based practice in this way, you can have a much more educated conversation with them about that's not what evidence-based practice is. Okay, you can reference kind of that 3-part model. The other thing I always like to say is, you know, if it was just about the research literature, then you wouldn't need clinicians. Okay, they would find a way to automatize all medicine, all therapies, by just following what the protocol is and leaving it at that. But it's not. It takes clinician skill, and it takes a consideration of the patient. So we're not robots in evidence-based practice. The next assumption is that an evidence-based paradigm is compatible with music therapy clinical practice, meaning that it can work. We have a number of allied professions, so even outside of medicine, where we use this, we use an evidence-based thinking with a lot of success. That it's not so rigorous. You have to follow the protocol, etc. Everybody's treatment looks exactly the same. And again, that's kind of a caricature of what evidence-based practice is. It's simply not what it is. And I'll point out in psychology, for example, in addition to being a board-certified music therapist, I'm also a licensed psychologist, and I've been trained in various techniques as a psychologist as well. And in cognitive behavior therapy, we do have manuals that we follow. But just because I might be following a manual doesn't mean that patient A's treatment looks exactly like patient B's treatment. I'm following a manual which provides guidelines on how to execute an intervention, but it doesn't tell me exactly how to execute the intervention. So applying that same thinking in music therapy, we may have guidelines on how to execute a particular intervention, but it doesn't give you a script. It doesn't lock you into some sort of scripted type of treatment. Again, that's a poor characterization of what music therapy and evidence-based practice would look like. Also, evidence-based practice or evidence-informed practice, they're flexible. And we make multiple sources of data and making clinical decisions. So we're not only looking at the quantitative evidence, we're also looking at the qualitative evidence, trying to get insights into the clinician that's carrying these things out, looking into and trying to honor the voice of the client who's receiving music therapy. And so when we're conducting any kind of research, whether it's more qualitative or interpretivist, or quantitative or objectivist, we are always looking at multiple sources of evidence. So we're maybe reviewing research literature, we're looking at documents, so that's the R. We're doing interviews, so we're using the clinician's voice, we're capturing the client's voice, we're making observations, and we're also conducting tests. So we're doing more quantitative types of things. So, an evidence-based paradigm is really embracing multiple sources of evidence. It's not just one type of evidence that we're looking at. And the third assumption is that although we have music therapy as an evidence-based approach, or it's an evidence-based discipline, we're not quite as evidence-based as we'd like to think. One of the things that I have noticed in my work for the past 20 plus years is that my colleagues will often come to me when they have a contract that they want to build with a new facility, or they're trying to argue for music therapy to be expanding in other areas of the hospital. And they are often asking me to help them find some research support or some sort of empirical justification for what it is. And I'm happy to do that. I'm happy to expand, music therapy practice, and I very gladly will do that. But that suggests to me that we're not very evidence-based if people are only coming to the fountain of research evidence in times of need, rather than always being at the fountain of research evidence all the time, so that my colleagues don't need to come to me and ask me about what's the research literature say about music therapy and ASD, because they've been there. That's what I want them to be. I always want them to be at the fountain, so they're always looking at and digesting the research evidence. So I would like to say that we're moving in the direction as an evidence-based discipline, but we're not quite there yet. So what gets in the way of us being more kind of grounded or steeped in a research culture or an evidence-based culture? And I have done, this is actually one of my areas of scholarship that I work on, so I've done some studies and research in this particular area. So we're going to look at these three things that kind of get in the way. And the first one is, let's look at the level of research activity, okay, that music therapists are engaged in. So to what extent are music therapists engaged in research-related activities? So I conducted a study, it was published a few years ago, looking at just that, looking at different behaviors, research-related behaviors that music therapists are doing. So one of the research behaviors that I looked at is how frequently are music therapists reading journals. And if you're an AMTA member, this is one of the best conduits that we have of getting research to our members. And it's nice to know that of those that were surveyed, well over half of the music therapists in my study were either frequently or sometimes looking at the research, looking at the journals. Okay, so and that's a good thing. Okay, so over half. The next question is, how often were music therapists attending research sessions, maybe at conferences, how often was that happening? Well, we don't see that happening quite as much as we see journal reading. Okay, so the majority of people either rarely or never attend any kind of research conferences or sessions. The next behavior that I was looking at is how often are they involved in conducting research or participating somehow in collecting research evidence. And again, we see rarely or never our music therapists doing that. And again, the people that tend to be engaging in research are those that are at universities or maybe graduate students that are involved in research. This doesn't surprise me so much because really we're not a profession that's built entirely of researchers. I mean, we need to be a discipline of clinicians. We certainly wouldn't be serving our clients very well. We'd end up being like Dr. Z's in the cartoon we just looked at a few slides ago if we were a discipline completely made of researchers. And the last behavior that I was looking at is, how frequently are music therapists discussing research with their colleagues. So this is, it's certainly happening more frequently than conducting research or even attending research conferences. So again, by and large, music therapists are talking with their colleagues about research. And this is certainly something that I'd like to see even more frequently, something that's occurring. So certainly with regard to behavior, different research behaviors, we don't see the behaviors occurring frequently. But what we know is that those with higher education tend to report more research-related behaviors or activities. We also tend to find people working in rehab settings or in medical settings. They tend to report more research activity or research behavior than those that are working in, let's say, educational settings. And we also find that people that are in clinical settings, that people that say that I'm a clinician, music therapy clinician, rather than an administrative person, they tend to do more research-related activities or behaviors. And then again, those people that are in research or academic positions, they tend to report more research activity and behaviors than those people that are in clinical or administrative positions. And you might be saying to yourself, well, of course, this doesn't surprise me, but we can't just say that, well, we would assume that this would be the case. We need to have evidence that really suggests that. So what this outcome really says to me is that not all areas of the music therapy profession, as far as occupations, are looking at research or engaging with research quite as frequently. We would like to see maybe administrators, maybe with more frequency, looking at the research literature that's available so that they can maybe supervise or even guide maybe some of the clinicians that are working for them, so that other administrators can talk to other disciplines about what it is that music therapists are doing and what the research evidence is saying. And so we want more engagement across the occupational roles in our profession to be engaged in research. And the third assumption is that a lot of our music therapists are not engaging with the research evidence. Okay? Meaning we have a lot of clinicians that really feel maybe a little bit disconnected, that are disconnected from research. So one of the ways I'm making this claim are based on a couple of studies I've been involved in recent years. And one of the ways we can look at how connected or maybe relatively disconnected are music therapists from the research is, what about their willingness to participate in a survey about research? So in the earlier study, the study I talked about before, I used an AMTA sample. Okay, so I invited over 3,000 music therapy music therapists, members of AMTA, to participate in this study. And of those, about 30% responded to the study. In the study that Dr. Barbara Wheeler and I did, we used a CBMT sample. Okay, so we invited board-certified music therapists to participate, and we invited over 6,000 board-certified music therapists to participate, and only 16% of those people invited participated. So already we have a different response rate between AMTA members and CBMT or board-certified music therapists. This would suggest to me that they're not exactly the same, meaning it looks like, it would appear that AMTA sample is more likely to engage or participate in the study or survey about research compared to clinicians. So the AMTA sample is not going to just be made up of clinicians. It's going to maybe made up of researchers, etc. The CBMT sample is made up of just clinicians. We can drill down a little bit deeper. So in the first study, so the 2015 study, if you look at the 974 people that responded, okay, 89% of that sample, the people that actually responded, the 974, were MTBC, and 11% were not MTBC. So by and large, they were board-certified music therapists that were responding to that first study. So of that AMTA sample, AMTA members, 89% of those folks were MTBC. If we look at the CBMT sample, so the board-certified music therapist sample, we're looking at this time how many of those members were members of AMTA and how many were not. Well, of the 980 people that responded to the Waldon Wheeler study, 86% were AMTA members, while 14% were not. What this tells me is that AMTA members in general are more likely to participate in a survey or a study about research over and above just CBMT members. If you remember, I mentioned before that journals are one of the ways that the association can get research to our members. Maybe one of the things that makes an AMTA member more likely to engage in research is because they're getting a constant flow or a conduit of research that's coming to them. This would also suggest that the majority of board-certified music therapists, they're not getting maybe a regular pipeline of research evidence, and maybe they're not going to be as engaged with research for that reason, not getting a constant flow. But they're also, their inclination isn't really towards, it wouldn't appear to be engaged in participating in research. So I find that a little bit concerning, that the majority of our clinicians appear to be somewhat disconnected from the research process. Now again, it appears to be that way. These are only a couple of data points that we have. We need more research to maybe investigate this a little bit more closely, and even doing some qualitative studies to drill down and find out, well, what are clinicians thinking about research in general, and how relevant do they think that is? Something that that Dr. Barbara Wheeler and I actually also looked at in that study. Further looking at what is getting in the way of music therapists actually incorporating research findings into their clinical practice. So I was interested in looking at that as well in the Waldon 2015 study. So there were 4 different types of things that get in the way, or what we'll call barriers. Okay, so these are 4 different barriers that could potentially get in the way of a music therapist integrating research evidence into their daily practice with their clients and their patients. And so these barriers were actually were devised through nursing research literature, and they developed a tool that actually can measure the extent to which these barriers, or how much these barriers are getting in the way of a clinician integrating research into practice. So the first barrier that we can look at is the adopter. So kind of the attitude of the clinician. They don't see any value in integrating research into what it is that they're doing, or they feel really disconnected from the research, or they don't even know about research. So those are adopter barriers. The next one are organizational barriers. This is where the place of employment doesn't really allow space or time to look at the research literature. So there's no time given to the clinician working in a particular facility or an organization. Or maybe the facility won't allow them to integrate research evidence into the music therapist practice. The next one is an innovation barrier. This is where the research literature itself is not very strong, or where the literature doesn't really isn't replicated enough. One of the big criticisms, I think, in our music therapy literature that's often raised is that many studies are done on the effects of music therapy on some sort of outcome, and that's kind of it's an odd type of a study setup where we're not studying the effects of a discipline on an outcome. So let me put it this way. You wouldn't read a study saying the effects of psychology on anxiety. You might be laughing to yourself because that sounds kind of ridiculous, because psychology is a discipline. But why is it okay to say that, the effects of music therapy on anxiety? What we should be doing is we should be looking at specific interventions on certain outcomes. So as we're looking at psychology literature, we're going to be looking at the effects of exposure-based therapies on anxiety. In music therapy, why aren't we looking at the effects of music-assisted relaxation on anxiety? So our literature really should focus more on interventions and not looking at music therapy as a discipline, because that's just not appropriate. It's not appropriate to do. We wouldn't set up a study that looks at that. We're looking at music therapy interventions on outcomes. So those would be innovation barriers, like the research literature is not sufficient or not adequate. And then finally, we have communication barriers, meaning that the clinician finds that the research is not readily available to them, that it's difficult to interpret or read the research evidence, and sometimes the communication has to do with it's hard for the clinician to translate what they read in the research literature into the field. So those are our 4 barriers. So adopter, organization, innovation, and communication. And so in my study, I looked at these different barriers and wanted to find out, which ones were getting in the way the most. And so one of the findings I looked at was, well, how do clinicians perceive, these barriers? And they found that their organization, so their facility, was getting in their way the most, followed by communication, which is kind of accessing and understanding the research and translating that into practice, which is then followed by innovation and the adopter. But when I looked at, music therapy educators, researchers, well, they actually looked at the barriers differently. They really found that limitations in the adopter themselves was more of a problem. Okay, meaning that the clinician was not. They perceived the clinicians not being able to understand or even use the research because they lack an understanding. And then they criticized the type of research that's there. So they criticized the quality of the research. And then finally they looked at communication and organization. So I think what's telling is that clinicians see facilities as getting in the way the most, where educators see facilities as getting in the way the least. And I think that there's a mismatch here, where the researchers aren't really picking up on the same barriers that the clinicians are. So there's more work that needs to be done here, and I think that it would be important to honor the clinicians' voices in understanding what are their views, what's getting in the way from them, implementing research into their clinicians, into their clinical work. So let me kind of wrap up much of what we've talked about here. So an evidence-based paradigm is desirable, and again, that's my overriding thesis of this discussion. In the music therapy, we're not quite as evidence-based as we'd like to perceive ourselves to be. What are some challenges? Well, number one is we don't have a great infrastructure for building a lot of research, and that means we don't have a lot of researchers in our profession that are exclusively doing music therapy research, and we don't have a lot of clinicians that are engaged in research either. What I would say is that we need more clinicians working with researchers to help build our body of research evidence. So I think that's really important. And if you're familiar with the Music Therapy Research 2025, what we call MTR 2025, that's one of the needs that they've identified. One of the areas that I think that we need to work on is integrating more research competency into education and clinical training. I have a lot of colleagues that are physicians, and I'll ask them, how is it that you learn to embrace research so much? And that's because when they were undergrads and they were getting degrees in biology, etc., that they were really taught to honor and kind of stand at the fountain of research very early on in their training. And my thought is that that's what we should do in music therapy. We need to steep students in a tradition of research very early on so that it's not something that's left for later in your training. And it's something that we need to constantly integrate. We constantly need to lead students back to the fountain of research. We need to integrate it in our clinical classes constantly and have conversations with students about research throughout your undergraduate training and also into your internship, having conversations with your clinical supervisors about it. Research should not be something that is only left for the hallowed institutions of universities and colleges. We need to have research in the workplace. And we need to improve the clinicians' connections with research as well. I think it's important for us to have research sessions at conferences or provide continuing education opportunities for clinicians so that they can more easily engage with, have a warmer familiarity with research. So I think that would help as well. We don't need a profession of only researchers. That is not what we want. And I told you that. Research is also not just for graduate level clinicians. There's nothing that says that an undergraduate level music therapist, there's no reason that they can't engage somehow with research. Should research be seen as something that's special? No, it shouldn't be something that's special. Research activity, whether it's reading research journals, discussing research with colleagues, participating in a research study, or attending research conference sessions, is not something that should be special. I think it should be something that's done as a matter of course. Simply having research, having one study, for example, doesn't make a profession evidence-based. And I think that Tony Wigram a few years ago, that many base practice on tradition rather than research evidence, meaning that many music therapists appear to be basing their practice on how they were trained when they were students, rather than going back to the research literature, the current research evidence, and making changes. So how often are music therapists opening their journals and making changes to how they practice? I say it all the time. I want music therapists to go into the research journals as frequently as they tune their guitars. So how can we encourage a more evidence-based culture in music therapy? Well, I think it's a shared responsibility between education programs, internship training programs, and clinicians. It's not something that's a single responsibility of any one of these. So what can you do? Well, as a student, engage with your professors about research. Talk to your supervisors about research. And talk to your clinical training directors at internship sites. Have conversations with them about research. And I would tell clinical training directors is let your interns see you looking at journals and reviewing research. Read your journals and start up conversations with your colleagues about what it is that you're reading. Watch music therapy blogs and podcasts that cover research journals. Janice Lindstrom, she has a music therapy journal club that she broadcasts. Check that out. Look at the music therapy research blog by Dr. Lagasse and Dr. Knight out of Colorado State. Watch those blogs. Subscribe to those things. Find a way to engage yourself with the research literature. And then start a journal club at school. It's kind of like a book club, except that you have a group of students, you get them together, maybe over pizza, and have everybody read an issue of JMT, and then come and talk about what it is that you're reading over pizza. We can make this fun, but I think it's really important that students themselves have an interest and an engagement with research early on, something that you can hopefully continue throughout your careers. So here are some of my references, but you can certainly get a hold of me as well, University of the Pacific, or stop me at a conference sometime if you see me. This is something that I'm really passionate about. You can talk to any of my students that you might know that research in our profession is very important. It's what keeps us moving forward. So I hope you enjoyed this podcast or this virtual master class. And if you do have questions, please don't hesitate to contact me. My email is ewaldon@pacific.edu, or you can go straight to the music therapy website as well, and you can look me up.